Hello, and welcome to the rebroadcast of Incoming Tides and What It Means for HTAi, the Rise of Real-World Evidence, Big Data, and Artificial Intelligence. As we wait a few minutes for further participants to join, I will share a few slides with you about this workshop and the society itself. The 2020 annual meeting panel and workshop abstracts were reviewed by HTAi and its independent reviewers. HTAi had no involvement in the creation or development of the content and presentations for this session, and is providing a platform only for presentation of such content and presentations. The 2020 virtual program includes oral, panel, plenary, poster, and workshop presentations being broadcast live throughout the rest of the year. The link to the full program can be accessed by following the link in the chat box section of your GoToWebinar control panel or accessed via the HTAi 2020 website. We'd like to take the opportunity to thank you for being an HTAi member and remind you that as a member, you are invited to join one or more of the HTAi interest groups. To learn more about our interest groups, please see the link in your chat box. Participants throughout the presentation will remain muted. To submit any questions during the presentation, please use the questions functionality on the GoToWebinar. This may look like either of the two images shown on screen, depending whether you have joined through an app or a web browser. We will do our best to respond to questions within 48 to 72 hours. Thank you for joining us, and I will now begin the rebroadcast session.
Thank you. Well, welcome everybody to this HTAi virtual presentation of the third plenary session. About a month ago, we originally planned to be in Beijing, and as we know, the coronavirus has changed the world in many ways, including our ability to come face-to-face in Beijing. But I would like to thank both Kun Zhao and Professor Yingyao Cheng for their work in getting such a fabulous meeting together. And I'm so sorry that we can't meet in Beijing. However, the third plenary is really our first presentation of the plenary. And as you can see, the title is Incoming Tides and What It Means for HTAi, the Rise of Real-World Evidence and Big Data. And I'm both the chair of the Scientific Program Committee for Beijing and also chairing this third plenary. And we have three very exciting speakers tonight who will, I'm sure, enlighten us more on these topics. I'll introduce all of the three speakers at the start, and then they will present, and then we will have a question and answer session. So our first speaker will be Dr. Terry Sweeney, who's a health economist from Cambridge and has worked extensively in the NHS on big data and IT systems. But subsequent to that has moved internationally and worked in China on the 2030 plans, as well as Japan and the USA, and is now currently working in Australia. Terry brings a commercial aspect to healthcare, but services that healthcare providers will want and will produce or provide to us many examples of the use of artificial intelligence. Our second speaker will be Dr. Kang Zhang. Kang is an American physician who moved to Macau and Guangzhou because of the opportunity to access big data in large populations, has a specific interest in machine learning, but also in epidemiology and contribution to healthcare systems. And our third speaker will be Professor Claudia Pagliari, who's from the University of Edinburgh. She's Director of Global Health, and Claudia has extensive experience in data, in epidemiology, in the social issues surrounding these things in healthcare, and will bring a public health perspective to the various issues that we'll be considering tonight. If I could have the second slide, please, Denise. And what I've put there is one of many definitions of artificial intelligence. This is a brief one, but there are many others. What I'm trying to explain is that in tonight's session, we cannot cover the field totally because it is so massive. But hopefully the issues that come from the speakers will be illuminating and of interest. I've listed some of the technologies that are used in artificial intelligence. Many of these have been around a long time, but it has been the ability to link these varying technologies in a new way that has produced the changes that artificial intelligence is linking. Finally, I'd like to acknowledge Lucy Henry, our scientific director, and Denise Jarrett, who have worked hard on this program and have put this and the other plenary sessions together. So we'll now move into our first speaker, and Terry, I'll hand over to you.
Thank you so much. Just getting into presentation mode, folks. And Brendan, I'm just going to do a sanity check. Can you see my my initial slide?
Very, very clearly and well. Yeah.
Brendan and team, thank you so much for the invitation and opportunity to speak with everyone. Well, tonight my time. It's just gone 5:30 p.m. here in Adelaide, South Australia. I hope everyone is safe and well. We certainly live in interesting times. I thought I would kind of kick things off and talk to you all about, I guess first the data. You know, we talk about the data is the new oil, and it absolutely is. So I just want to talk a little bit about the information that's available and that we can tap into, and a little bit about the technology and how technology has changed over the last little while, up to, you know, where we are now with artificial intelligence and machine learning. And then talk about some practical real world examples of how we're applying the technology to the information to get meaningful insights. And I'll share a few examples of some areas that I've been personally involved in, and we'll go from there. Okay, so we've got a beautiful backdrop of my current home, Adelaide, South Australia, there on the screen. So I guess I'll start by saying, you know, we have a lot of challenges in global healthcare, but also a lot of opportunity. You know, some of the challenges, of course, are related to cost and rising costs. So certainly here in Australia, we're spending about 9% of our GDP on healthcare, and that's quite typical of OECD nations. Of course, the US is kind of off the charts in a number of different areas, and I wanted to put that particular stat up there because it's quite remarkable actually that the US is currently spending almost 18% of GDP on healthcare, and it's growing at a very rapid rate. We also know that roughly 30 cents in every dollar that we spend in healthcare is wasted. A lot of that is error, and you know, not really tapping into the information that's available. And at the same time, we're seeing an explosion of information. So every day in the world, we're creating about 2.5 quintillion bytes of data. Any given healthcare organization probably only gets meaningful insights from about 15 to 20% of the data that they hold. And by the end of this year, healthcare related information will double every 73 days. So we've got rising costs. We've got a lot of waste in the system, but at the same time, we've seen an explosion of information. When we think about some of the challenges that what I call our health heroes, the people that are on the front line delivering health services to patients and citizens, we have a lot of challenges, a lot of global challenges. So I've just highlighted a few of them on this particular slide. The one that interests me is top middle. I have a lot of friends who are doctors, and they talk about this as being pajama time. So it's the time outside of clinical practice that they have to read to really keep on top of the information that's relevant to their particular discipline. And as you can see from that stat, you know, a typical healthcare professional would have to read 167 hours a week just to keep on top of the information relevant to their job. Now that's impossible, right? So there's a lot of information that's not being used. We also know that currently, and here we are in 2020, less than 50% of medicine is evidence-based. So more than half the decisions that are being made about a patient's health and well-being is based on evidence, and that's often because the evidence either isn't there or it's there and it can't be seen by a doctor's capacity to ingest that information, and until very recently we haven't necessarily had the technology to see it. You know, obviously we're living in a COVID world, and two things we're seeing typical of a global pandemic. And number one, trust in government rises. So trust in government is very, very high right now. And also trust in digital technology is a little higher when we think about typically as a patient, the balance between my privacy but also my safety. Often in times like this, in the middle of a pandemic, we put safety paramount over the perceived issues around privacy, and hence technology is in healthcare is confidence in technology in healthcare is very high right now. Here in Australia, we've seen 7 million downloads of what we call the COVID Safe app, which is the contact tracing app that we have. So very high confidence in tech, and you'll see from the bottom right there, you know, over 75% of patients are expected to use some type of digital health service in the future. Individually, we will generate in our lifetime about 1,100 terabytes of healthcare related information. Interestingly, when we think about healthcare, we tend to focus on clinical factors, but ultimately that's really only 10% of our overall health. 30% is based on our genome and genomic factors. 60% of our health and well-being is really related to non-clinical, external, what we often call as social determinants of health. These, you know, diet and exercise are the obvious two, but we also have things like education, employment, housing, family, community, are all external factors that have a big impact on our life. And I guess the trick with the information is to use all of that, the clinical and the non-clinical, together to generate some meaningful insights. And a lot of the information that's being generated is not just text-based. You know, with the increased use of wearables, here I am with my Fitbit. You know, audio information is being used more and more in healthcare. Of course, imaging, video analysis, the variety of data that we're generating is becoming, it's increasing, and it's becoming more varied. And I guess this slide just illustrates the point that the information really that we want to bring together, it comes from a lot of different sources. And of course, we know that data is or can be at the center of prevention, diagnosis, and treatment. And I guess the trick is to use that information, whether it's on an individual or a population, and move the people along the continuum of health, from a disease state to a healthy state as much as possible. And of course, try and catch early, right? So look at prevention and how can we use the information to prevent the onset of a chronic disease, for example. Okay, so explosion of information, rising costs in healthcare, an explosion of data, both personally and as populations. And at the same time, we've seen a real shift in the technology. We've gone from the old tabulating systems that add things up to a lot of technology that is still being used today, which is the programmable systems, very logical, tend to use static information, and run rules based. If X, do Y. If A, do B, and using static, often text-based information through to artificial intelligence. And I put down there 2011 because it's really at 2011 that I think that we turned a corner with AI and machine learning, and it was probably at that point that we had the computing power, the processing power to really crunch the information at scale. And artificial intelligence has actually been around since the 1960s. We just haven't had the processing power to process all of that information. Now we have. Just I guess highlighting the difference between the typical rules-based logical system versus AI. We know with AI that we train the AI in a similar way to how we train our brain. We use data sets to do the training, and algorithms, obviously, to analyze that information and drive insights from that information. We know that with technologies such as deep learning, that the AI can learn and improve the more it's used and the more it experiences, and is very, very good with all types of data, text-based, but also audio, video, and other types of information, the kind of non-traditional data, and has an insatiable capacity. At IBM with IBM Watson, we have Watson being able to ingest 800 million pages of unstructured information per minute. 800 million unstructured pages of unstructured information per minute. It's quite remarkable. So when we think of AI and machine learning, I like to think of it, and this is a simplified version of kind of its capability, being able to understand the data and understand context of structured and unstructured information at a huge scale. Reasoning, so AI has the ability to hypothesize and come up with what ifs. Learning, the more data it is trained with, and the more we use AI, the smarter it gets. And it has the ability to empower us humans. So seeing what was previously invisible to the human eye. I tend to refer to artificial intelligence actually as augmented intelligence. So trying to get across the point that certainly we're not yet building world-dominating robots to take over humanity. We really, where we get the best out of the tech is when we actually get the best out of humans. And I certainly see technology and humanity being a partnership. The machines are very, very good at certain things. The capacity to ingest and interpret information. The ability to identify patterns where maybe we can't as humans, the ability to reduce human bias is all very, very good, and the machines are all very good at doing that. But as humans, we're very, very good with things like common sense, morals, compassion, imagination, abstraction. So for me, the combination of the best of humanity and the best of technology is where we see things getting very, very powerful in healthcare. And it's all about getting actionable insights, really looking into the information and what can often seem like disparate, unrelated information, and translating that into actionable insights that we can take on a patient. And when we talk about healthcare and technology and how it's being used, obviously there's the traditional interaction between doctor and patient, but I think we do need to consider the entire ecosystem of healthcare and the information that we're looking at, not just the the patient record or the EMR, but if we look at the healthcare providers, the insurers, policymakers, so government have a big part to play, the pioneers, so that's more like medical research, the product manufacturers, so big pharmas and hardware manufacturers, all have a part to play and have a piece of the puzzle for patient wellness. Now we'll get into some examples of how this is being used in practice. So actually here in Australia, we've been looking at what we call giving AI eyes and building cognitive detection advisors. So the ability for the AI to look at images and try and pick up different anomalies. What's a normal image from an abnormal image, and if it's abnormal, what is that abnormality? And having a certain degree of clinical reasoning in that technology. And certainly, around the world, melanoma, skin cancer, is a big problem. Here in Australia, it is what we call our national cancer. Someone dies every 6 hours in Australia from skin cancer, which is remarkable when you think that actually it is highly treatable, and if it's detected early, the survival rate is around about 98%. But given the death rates in the US, it's also a significant problem. Someone dies every 57 minutes in the US of skin cancer. So we started to look by training the AI with 42,000 images of the skin, good, bad, and indifferent. Annotate those images and use it to train the AI into detecting melanoma with a smart device. We're seeing some remarkable results actually. A GP with the naked eye has a success rate of diagnosing melanoma of about 65%. A specialist using a dermoscopic attachment is with the eye is getting a success rate of about 75%. But with the artificial intelligence, we're seeing success rates of about 92%. So a marked improvement over the human eye. Another example is in audio. So that was visual. Another is around audio. So we're doing some work in a lab that we have in Melbourne around speech analytics to detect dementia early onset of dementia, also risk of dementia. So we're doing that by taking a subject, we're telling them a very short story, maybe it's a sentence or a paragraph, and we're asking them to recall that information immediately, and then again after 5 minutes. And when the AI is analyzing the speech patterns, we can predict a risk of dementia. So what's next? So that's kind of some of the things that we're doing right now. Thinking about what's going to be impactful in the next 3 to 5 years. I think we're going to see a reduction in keyboard interaction with systems. I think the ability to have embodied cognition. So having AI in a whether it's in a robot or some other vehicle, in interacting in it naturally with the AI naturally. So we've got services like voice to text, text to voice. So more conversational interactions with artificial intelligence, I think, is something that we're going to see, and a little less on the keyboard. A couple of examples there that I've been involved in: Neo, which is an AI-powered robot, which is used at the Hilton Hotel as a concierge service, and you can book a table at a restaurant or tickets for a show at the theatre. And Pepper at the bottom, which is in a bank in Tokyo, and it's offering advice and guidance on financial services products. Obviously, we're going to be able to see that being used and translated over into healthcare. I guess the next advancement that I'm excited about is developing the next generation of microprocessors built on the human brain, designed based on the architecture of the human brain, and trying to capture that left brain logic and right brain emotion. So we know right now, you know, and certainly at IBM, we have the most powerful quantum computer in the world. But as you can see from the picture there, the power capacity and the space is quite large. We require a power plant worth of energy to power these new wave of supercomputers. But the human brain is very efficient, right? Very fuel efficient, and we've got 98 billion neurons in the human brain, and it can run off 20 watts of power, which is the equivalent of eating a sandwich. So what I'm excited about is this, what we call brain-inspired computing. So building the microchip and the processing power based on how the brain works and operates, and really getting the size down, and also getting the power down as well, the power usage down as well. And I think that's useful where we talk about wearables, and again, I have my Fitbit on. But often with wearables, when we talk about health in the home with sensors at home, it's not necessarily real-time processing. The sensors are picking up information, passing it up to the cloud, which is processing and giving a result back. But I think with the brain-inspired computing and the next generation of those microchips, we're going to be able to, change wearables to thinkables and have on-device real-time processing to give us immediate feedback. And a reason that might be quite useful is if we think about fall prediction, whether someone has epilepsy or they're elderly and they have a higher risk of falling, we do have sensors that can help predict when a fall might take place. But it's just not immediate, it's not real time, and it's not on the device. So I think these thinkables will be something that we'll see being more prevalent in the future. And I guess finally, and this is my last slide, we have a duty when we think about ethics of artificial intelligence, which is a big topic right now. I think we have a duty of care to ensure that the AI is developed in a way that it's number one, it has the right purpose. So the AI is there to support what humans do, not replace humans. I think there has to be an element of transparency. So when we think about computers, we think about a black box. You put information in and you get an answer out. But with healthcare, it's very different, and we really need to see the math. So for me, I think of it as a glass box. I want the result, I want the answer, I want the recommendation, but I want to see how it's been worked out and what evidence was that recommendation based on. And that's something that we absolutely need in healthcare. And I think the third factor in considering AI is skills, making sure that the people, the humans that are training the AI have the right industry skills, and we have the right professionals training the AI for the purpose that it's being developed for. And folks, that's the end of my presentation.
Thank you very much, Terry. That's fantastic. As I indicated, we'll go straight on to the next presentation, and we'll have questions at the end. So, Dr. Kang Zhang, are you set to go, please?
Yes, I'm set to go. Denise, would you mind put up my slides, please? And good afternoon or good morning, depends on where you are in your global locations. Greetings from Macau University of Science and Technology here in China. And what I actually want to do today is because I actually have some trouble with my video, so our coordinating center Denise is gracious to actually allow me to speak and to you, and then I will ask her to advance the slides for me. Next slide, please. So what I like to do today is actually give you some examples of what we and how to apply artificial intelligence and big data to healthcare. You have heard the wonderful talks and introductions from Terry, and that served as a great actually segue for my presentation, which I will give you lots of examples how powerful and effective that AI has been applied to health and healthcare systems. So this is actually a review I wrote with some of my colleagues in China on how to implement artificial intelligence in medicine. Next slide. So essentially, we are dealing with two fronts. Next slide, please. So one of which is how to go ahead using the AIs in healthcare. Most of us are now dealing with the first actually dimension, which is diagnostics on your left upper side of the corner, and that includes a lot of prenatal diagnosis, early detection, etc. And I will touch upon a little bit. And then we are gradually moving into the second dimension of diagnosis, which is AI-based therapeutics and human AI interactions. What's going to be actually going in the future is the population health management. What we should do is not only treat the patients that have disease already, if we can identify those patients who are still in the pre-symptomatic or early stage of disease and to intervene, hopefully change the disease course and actually reduce the healthcare burden of the disease treatment strategies, that would be ideal. And then obviously the big data and will help our regulatory bodies and administrations to design and implement better nationwide or globally healthcare policies such that we can actually together reduce disease burden. This is not even more acute in the situation of COVID-19, where a global coordination of fighting this terrible disease are urgently needed. Next slide, please. So at the health information level, and obviously that can be flow in multiple directions. Obviously, the patients and the regulatory bodies and healthcare physicians and healthcare systems. So Terry touched upon some of that and how we can actually integrate those systems and ideally empower them in the individual level, at the patient level is actually ideal. So we are actually using some of the technology towards a unified system and implementing them in cities like Guangzhou and as a test case. So next slide, please. Obviously, there are many other things to actually give you examples. So I'm going to give you the first example of how we actually did this. So one of the studies we did is using optical coherence tomography, or OCT, which is the most used diagnostic tool in ophthalmology or eye care. What it is, it's a beam, light beam, which will non-invasively imaging retina in the back of your eye. Within 30 seconds, it can take 30,000 slice scans, just like CT scans, and then give you an idea what kind of disease that person has. So using this technology, next slide, and using about 250,000 optical coherence tomography slides, we were able to diagnose this disease. What we actually was doing here is to apply a technology called transfer learning. Transfer learning meaning you can just transfer knowledge or prior learned knowledge to a new tasks. For example, if someone learned how to play volleyball, that person shouldn't actually starting from actually walking again, and then should be just going to use that skill to go and learn how to play basketball or volleyball or actually another football. So this is a similar idea that we use for training a AI system that has been recognized or being trained to recognize pictures, for example, human face, a car or dog and a cat, to recognize a medical imaging, in this case OCT. Next slide, please. So in this case, we were able to train our OCT images, which is on the top, in recognizing different diseases, and that achieved a very high accuracy. Next slide, please. So in this case, it achieved a 90% accuracy for these conditions. I will actually come on to tell you our next example of this, which is using computed tomography in combination with artificial intelligence in diagnosing COVID-19 pneumonia. As everybody knows that upon this pandemic, especially in the early phase of pandemic, whereas in Wuhan, we did not have sufficient diagnostic nucleic acid-based diagnostic kits. Therefore, an alternative is urgently needed. And the computed tomography is very, very common equipment in Wuhan, in China. And so we, however, and then the scanning only takes 10 minutes. However, reading the a scan, which consists usually of 200 to 400 slices, will take a radiologist, even an experienced radiologist, about 20 minutes. And obviously, that actually took a lot of time. And in this situation, none of the physicians were very familiar with the characteristics or features of COVID-19. So in this case, we developed a system, AI system, which were trained using 500,000 slices of CTs over 5,000 patients. Today, this is one of the probably the biggest studies using CT scan to diagnose COVID-19 disease. Next slide. And this AI system, upon training using both segmentation technology as well as end-to-end feature detection, was able to give very high accurate diagnosis of 6 types of the lesion features, including ground glass appearance, consolidation, fibrosis, provo effusion, and honeycomb degeneration, etc. Next slide. And I was able to give physicians a diagnosis as well as point out the lesions within 30 seconds. So dramatically reduced the time for diagnosis. In addition, it was able to help junior radiologists in this slide here to dramatically improve the performance from accuracy of 60% to a senior radiologist level, which is about 90 to 95%. Next slide, please. Obviously, these systems not only can help the physicians to do the diagnosis, it can also use to detect as a screening tool. So in this case, we were able to, next slide, please, to do triage analysis, especially now in China. They were used for scanning after reopening of the economy and go to work. Next slide, please. They were used for essentially in the fever and the cough clinics as the first line scanning tools to diagnose COVID-19 pneumonia. We are able to use also big data and the clinical metadata to correlate with lesion size. For example, we now know that the albumin level, the age, older age, or oxygen saturation play a key role in prognosis, and that was actually not available at the time, and was able to be picked up by the big data. Next slide, please. We'll also be able to form a diagnostic prognostic predictions, and by taking the initial admissions CT scan and some metadata, and we'll be able to tell which group of patients will be able to, or very likely to progress into critical illness by being admission to the ICU or putting on the mechanical ventilation or death, and the time to achieve that, to arrive at the clinical illness. That actually was able to help physicians to actually allocate precious healthcare resources to intervene to reduce the mortality and severe complications. Next slide, please. In addition, this actually HTAi system is able to quantify the lesions, different lesions. This is actually very helpful in evaluating treatment outcomes. For example, here, the 3 drugs before, after treatment, by looking at the lesion volumes, we're able to actually see whether they were able to reduce the lesion size or volume. Next slide, please. So these systems, since its inception, was able to actually being implemented in China widely, and it's now the we also put the codes as well as the our slices, CT scan slices on the China National Center for Bioinformation, so we can actually assist the worldwide combating this coronavirus. And now, so far, the system and codes has been downloaded more than 3 million times, and has been used widely within China, including in Wuhan and business hospitals, as well as in many large hospitals in China, as well as in globally in United States, UK, Australia, Iran, Iraq, and Ecuador, etc. And we're very pleased that we're able to contribute to the COVID-19 diagnostic arena. Next slide, please. So, so this is actually a viewing of our program. Essentially, upon uploading to the cloud, then the server within 20 seconds, it will give essentially the outline of the lesion and give a probability of if it's actually COVID-19 pneumonia or bacterial pneumonia or viral pneumonia or normal. And obviously, this system can be expanded to diagnose other diseases as well, including lung cancer or TB, etc. Next slide, please. And so this is again just an example how actually it will generate automatically a radiological report for the physicians. Next slide, please. So this is actually an example what Terry has been alluded to earlier, that a powerful technology can really free the physicians from tedious manual work, and then allow them to synthesize new information, talking to the patients, increase the patient human physician interactions. Next slide, please. So what I actually want to actually show you is, next slide, please, some other examples that we did for using AI to solve real-time clinical problems. Next slide, please. In this case, I'm actually going to talk about actually using retina images for detecting some of the common eye disease and systemic disease as well. So as you know that retina is a only organ or neural tissue or central nervous system that is actually outside cranium, and you can shine a light and then take a picture, and you can actually see the pathology due to diabetes or stroke or hypertension or kidney disease, and etc. Let alone to say that there's many blinding conditions such as macular degeneration, diabetic retinopathy, glaucoma. Next slide, please. So what we actually was able to do is taking standard fundus photographs, and was able to screen not only for the conditions I told you, and also for myopia, where we were able to screen millions of children's eyes, and then I was able to come up with a diagnostic algorithms where we can take one time point of their data. I was able to project how much they're going to progress each year, and what's their final outcome of the myopia, and then hopefully, and then using that data to intervene and hopefully change the course of the myopia epidemic, which is happening in China and some of the East Asia countries. Next slide, please. So the last actually example I'm going to talk about is to using a combination of imaging and also electron health record to make a diagnosis of a particular disease. In this case, we're using a pediatric field as an example. So in this study, what we did is actually taking 1.5 million, 1.3 million electron medical records, and then this is actually raw data, and then I was able to actually first of all formulate some of the knowledge, and in this case we used 20 physician pediatricians manually curated or read 50,000 records. In using that records, we're able to generate knowledge, and using the knowledge to perform natural language processing, and using that actual algorithm to extract raw data out of 1.6 million electron health records to formulate a structured structured data set. And from there, we're able to train and to classify pediatric diseases with a very high accuracy. And we actually did a comparison in this case that the AIs was able to perform incomparably with mid-career pediatricians, which means they've been practicing for about 15 to 20 years, and they can outperform the junior and chief residents to junior level physicians. They're a little bit actually slightly inferior or than the senior physician, which has been practiced over 20-25 years. And but this is I want to remind myself that the AI only actually saw 1.3 million medical records. If we were giving the AI 5 million or 10 million medical records, I'm certain that they will be actually having improvements, and then perhaps actually they will be actually practicing on par with the senior physicians. So, you know, the AI can perform in diagnostic tasks comparable to physician does not mean that they will replacing physician for the tasks. Rather, I feel this is actually a great tool in assisting physicians to do the real thing they should do. For example, like I actually alluded earlier in CT scans, that we were using AI-assisted diagnostics to free the physicians of reading the CT scans, localized lesions. That actually takes anywhere from even an experienced physician 15 to 20 minutes, which will be done by an experienced AI system in 20-30 seconds. Then with that actually additional 15 minutes, the physician can do a lot of other things that the AI will not able to do, and including actually talking to our patients, formulate treatment plans, and also synthesize and new knowledge and advance. That's how the medical field will advance, and with human machine interactions. So this is actually an example that how we can actually using not just imaging-based deep learning, in addition, in combination with, for example, natural language processing to process and extract massive amount of data from unstructured electron medical records, in combination with other tools to really actually get at how we can use those data and tools to assist physicians for better diagnosis, for better treatment strategies, and also for better predictions of outcomes. Next slide, please.
2 minutes, Kang.
Thank you. So, so I hope I give you some examples of how powerful and illustrious that the AI can be applied to healthcare systems, and those examples are still in the beginning, and I'm sure there are so many great exciting things will come, and we're looking forward to be a part of this exciting transformation of healthcare by the AI and big data, and hopefully to share with you more results and progress in the next meeting. Thank you so much.
Thank you very much, Kang, for a very exciting talk and amazing things happening in Southeast China. Our next speaker is Claudia, and I'll hand over to you, Claudia. Denise, are we connected? Yes.
Hello, yes, I'm here. I've had some technical problems, so I will speak to you initially without any slides, but I very much enjoyed those last presentations. And what I'd like to do with you today is really talk about where some of these innovations are leading us, some of the softer issues around them, and also their implications for health technology assessment. This has been, some of these innovations have been really sudden and dramatic. Some of them have been slow and incremental. And to some extent, they've taken place sort of outside typical health technology assessment. I mean, in the context of this field as a whole, which I've been linked to for many years, we can think of lots of different things as being health technologies, and similar methods and questions have been applied, irrespective of whether they're something like a written clinical practice guideline, or a medical device, or a new pharmaceutical product, a surgical intervention. You know, these are typically much more sort of tangible programs or policies that have been introduced. So health technology assessment has this very broad church, if you like, and a broad set of questions and a number of methodologies packed in, some of which may be more or less applicable to these new innovations, which we are classifying as forms of digital health, if you like. Now, digital health, which is an area that I work in primarily today, is again a fairly interdisciplinary area, which is taking account of all sorts of uses of computing and online digital networks, and internet technologies, and new innovations such as artificial intelligence to support the delivery of care, to support research, and to support citizens' own health. They vary from mobile devices, so particular things that are close to you, to clinical information systems, to these new brands of innovation involving big data and artificial intelligence, as I've said before. Now, the big issue at the moment, or the kind of dominant funding source, if you like, funding target of major government investments worldwide over the last period, has been data-driven innovations and the promise of data science. So this has utterly transformed public health. It's utterly transformed actually the activities within medical schools, and many funding agencies, whether they are from normally deal with economics and social research, to those that typically deal with engineering, science, or health technology assessment, medical research, have been pivoting their funds over the last few years towards big data, towards data-driven innovations, towards this promise of this new bright future. And actually, to some extent, with some to some extent without really more of a sense of it being a promise for the future rather than something particularly tangible, and that can be a problem. But these data-driven innovations that we are focusing on they can be resources, they can be large data sets. We have much more, high-performance computing is become the sort of watchword. We have enormous databases that are gradually being aggregated, joined together in various forms. So we have also methodologies that are using all of these data and data sources, and some of those are things like artificial intelligence, and many of them are just very fast statistical processing and so forth. And at the same time, data-driven innovations can also be interventions. So we are, developing innovations such as personalized medicine, genomic medicine, which draws on not only vast databases of information about populations, but also about individuals, and processes this through often very high performance computing to produce these outputs that are highly personalized. And again, that's been a slow process over the last decade, really, with lots of promises of us all having our individual medicines out of some sort of computer-driven machine that will give us the product that's just right for us, to this period of realization that actually that's probably not very practical, and we've moved on to stratified medicine approaches where we're looking at perhaps differentiating prescriptions according to particular characteristics of individuals that are similar to those of groups of people, rather than for them personally, unless you happen to be extremely rich. So there's been this process of kind of great sort of heightened hype around many of these technologies, leading to experience and realization of their limitations, and in many cases this developing this kind of new way of working, a new way of approaching healthcare that perhaps takes into account some of those methods, but in a more realistic fashion. So those data innovations, if you like, these health technologies are, as I said, resources, their methodologies, and they may also be interventions as well. When we think of AI and healthcare, images that often flash into people's minds, or ones that are used in marketing for companies, for example, include massive data dashboards. Many of the examples you will see on the internet when you look up digital health involve a clinician surrounded by enormous computer screens on which there are sort of images of DNA and x-rays and brains and various types of graph. And the idea is that really in the future, or right now, that we will soon be surrounded by these banks of machines that are actually bringing in data feeds from multiple sources, visualizing them for us, enabling us to kind of interact with them and make decisions which are very agile and based on real-time data. So this is very much the vision of real-world data that we're seeing in the title of this program, and to some extent, that is happening to some extent. I first sat in one of these enormous panopticons about 5 years ago at Imperial College London, shortly before the visit of President Xi to the very same laboratory, and I was very impressed with real-time data feeds coming from blockchain trades or from medical records that were appearing in this great, wondrous cavern of information. And of course, at the time, my first thoughts were, well, who is going to get to control these enormous panopticons? And what does that mean for the state of power in medicine? And will we use that power responsibly? So, of course, as was said at the beginning, I work in the intersection between health informatics and health technology assessment, public health, but also digital ethics. So I am concerned with the responsible uses of this information. But in real life, we haven't quite got to that stage yet. We are still in the process of collating our data assets. And in actual fact, much of the data that we have in medicine or in areas related to medicine, such as to do with people's social inequalities, for example, which is gradually being linked together with their medical data of other people to generate new insights and also to inform new policies, for example, or evaluate the ones that we have already. Often those data are, they may be incompatible. They have different structures and forms. They may be very dirty and in need of cleaning. And they sit in lots of different places. So actually bringing them together to make meaning of them in this big data world is easier said than done. So large investments, including in the UK, but also elsewhere, have been put into developing these curated data sets of national, either routine health data collected from GP surgeries or from hospitals, as well as other forms of data, for example, business data from organizations on things like bed usage, but also increasingly personalized data that's coming in from devices that we perhaps wear or procedures that have been done on particular individuals. So big data it sounds very straightforward, but it is not very straightforward. It's extraordinarily complex data. You can have as big a data as you like, but if it's not very good data, then it's really not doing you much good. So it's all about data quality, and I think the attention has shifted very much in that direction. Just getting back to this concept of big data, it's not just big for the sake of it. It can be massive population data. Certainly the major investments, and there's even an international population data linkage journal now, and a conference series. Many people are interested in this. The data that is occupying much of this attention is indeed big data. It's coming from population-based data sets, and it's linking it together. But also there is very deep big data as well, which is from individuals. So there's lots of data about you that might be coming from your Apple Watch, for example, because it's coming in real time. So this is creating personalized feeds from lots of individuals, which are all ending up in cloud servers somewhere. But it's a different kind of data which says different types of things. And there are opportunities to link together that population-based data, those insights about what happens at scale, with insights about the individual. And this is where the personalized medicine is coming in. And also where we're hoping for innovations like artificial intelligence to make a difference, and likewise digital therapeutics. The concept of digital therapeutics is still fairly emerging, but it's based on the idea that we can provide particular devices or tools or data insights for individuals that can produce therapeutic advice, for example, a clinical recommendation. They bring together elements of clinical decision support systems, which have been around for a long time, and also individualized personal interventions. They are have to be evidence-based, and evidence is accumulating. Artificial intelligence is again one of these areas which has been around for many, many years. We have seen the first developments in artificial intelligence, as was said earlier on, around 30 years ago, and some of those same methodologies and same people are still active in the field. But what we have, as we heard earlier, now is the application of high performance computing and actually massive databases around the world which are able to come together and process this more quickly and at scale. But fundamentally, they're around automation, pattern recognition, and really just making our lives easier for things like medical image processing, and quite effective in many senses, just a new type of machinery. So those sorts of methods are fairly mature. But what we often hear about in the conversations about artificial intelligence is much more futuristic. It's synthesized human beings. It's things that communicate with you on an emotional level. It's these cognitive augmentation tools, or even implants that we might have that are linked to them, that are really where people become a bit more anxious. And create new issues. But I would say many of those things are still far away. There are innovations that work. We have artificial intelligence methods that are becoming much more intuitive. There's a new technology which has just been released this week, actually, as an open access, which aims to be able to do natural language processing on any type of information that you want, any type of question you have, and it will run AI over the internet and produce these results for you, which sound quite similar to what a human would have done. So it's perhaps not that far away. And we are developing cognitively convincing robots and algorithms that also can make us feel certain ways, and not simply see them as a machine, but also to some extent as a person. But they're still quite far away. So these are challenging times for policymakers. There's also customers for health technology assessment who have to make sense of what it is they're in fact being offered and what are the key questions for them. So classically, we have questions, in health technology assessment: is it safe? Is it effective? Is it worth the money? And is it ethical? Is it acceptable? And worth the money is a big question for us at the moment, because it can be, when we consider the vast amounts of money we are spending on these innovations for the outputs compared to other sorts of healthcare that we could be spending our money on, the jury's still out. It's still fairly early days. Some areas we can be automating and producing great efficiencies. Others are much more speculative, and that includes things like surgical robotics, for example, which is some evidence to indicate that in fact human beings may be better and cheaper and more easy to evaluate. One of the challenges is that with artificial intelligence, it can be sometimes, depending on the type of artificial intelligence, one of the ethical challenges around it has been how we dissect what has gone on in order to evaluate it, in order to attribute the effects to the intervention. And the newer forms of deep learning and other types of neural network learning can be somewhat impenetrable. It can be quite difficult to articulate the pathways to impact in the same way as it can be when we see something physical happening. This is not to say that we can't do this. There are many types of AI which are, can be perfectly broken down to their processes. They're pretty straightforward and transparent. But ethicists have spent a long time analyzing and anguishing over this concept of transparency in AI, and accountability of AI is dependent upon that. So that links to this question of, is it effective? What was effective? Safety is also a challenge in this area, because the law, particularly when it comes to kind of the legal representations of safety, is also quite difficult, because whilst we now can classify software as a medical device, that's a bit harder to do for innovations such as big data and artificial intelligence. So actually being able to attribute blame when things go wrong is quite difficult. So the safety can be unproven. There are artificial intelligence-based chatbots, for example, available on the open market and from certain providers, which will provide you with a clinical diagnosis or recommendation. And some of those have proven fairly controversial with the outputs they're giving in terms of what they're recommending for the user. Sometimes not tallying with what a clinical practitioner would offer them, and in some cases being fairly unsafe. This raises questions for where does the liability fall? Does it fall on the software? Does it fall on the manufacturer? Does it fall on the person who has misinterpreted this result? Does it fall on the databases? Where does the liability fall? These are as yet really unclear questions, and we haven't applied HTAi as effectively as we could have done. So I think those are just a few of the issues here, but I think it's important to explain that big data and artificial intelligence, they are methods. They are also methods that can be used as part of health technology assessment. So proven extremely effective in things like post-market surveillance of drug side effects, for example, on a population basis. So being able to identify, small signals of side effects at scale and rapidly, very effective, very useful. Other things, perhaps, we are still in the innovation space and still kind of awaiting that evidence and still waiting for a time when we actively engage those traditional health technology assessment expertise with the kind of very, very excited computer science that is developing these innovations as well. So anyway, that's really my summary, really, that we have this new form of methodologies that we can use for good, but at the same time, these also need to be the objects of evaluation. And we are still in the process of trying to develop new approaches and frameworks for doing this.
Thank you very much, Claudia. That was fascinating and very helpful. Lucy, are we now into questions, or should I go ahead with a question?
We have a couple of questions, but Brendan, I'd be interested to hear your thoughts if you have a few.
Yeah, Claudia, I was going to ask, existing HTAi methodologies have been built around drugs or devices or procedures or diagnostics, sometimes public health. But using these kind of technologies is very different. Do we use the same framework that we have, but take different approaches to examining safety and effectiveness and cost effectiveness? Or do we need a new approach to HTAi to handle big data and the artificial intelligence and the conclusions that are going to come out of this as they affect healthcare?
Well, I think there's many methods that we can use, and sort of many of the evaluation questions are quite similar in some senses, but they are, they have limitations. Can you hear me? Okay.
Yes.
I would say, we are looking really at complex interventions. So the frameworks for evaluating complex interventions are fairly useful here. Bear in mind that these are innovations which sometimes are still laboratory-based information. Some are still very sort of, even if you see them in the Lancet or the New England Journal of Medicine, sometimes they're just still very much at the innovation stage. So there are sorts of questions that the sorts of questions that we might have of them are different from the sorts of questions we might have if they've actually been rolled out, or if they're in fact inserted as part of a randomized controlled trial. Now, that in itself creates problems because, can you easily do a randomized controlled trial of these things, of big data? Not so easily. In fact, those methods are being used, according to sort of some of the kind of true believers, as substitutes for randomized controlled trials. And, quite nice to have them alongside them. But they're not the same thing at all. So our what are we actually evaluating here? We can certainly perhaps, would you necessarily have a comparator if you are looking at a massive big data study, which is perhaps produced some serendipitous result about the relationship between coronavirus outcomes and cabbage eating? There was such a paper that's been going around this week online. Apparently, lettuce reduces your I think you use machine learning. Lettuce reduces your outcomes, but broccoli increases it. So, I mean, the sort of thing, there's very great opportunities to produce garbage from this, and to sort of lose sight of the theory and the kind of common sense behind what we're looking for. So some of those questions for evaluating these technologies are, how sensible was it? Did it have a good theoretical basis? Actually, was it ethical? I mean, some of the questions that we have, a lot of this information is highly personalized, highly sensitive patient information. And it's all very well to have your, digital robot, for want of a better word, meaning an algorithm, go and collect this information, process it, make judgments about people. And some of that may be very ethical and pro-social. It might be about exposing inequalities. It might be demonstrating that a policy intervention has been more harmful than helpful. But once you get down into individuals, it can create all sorts of other issues, like labeling, for example. Is this a person who is, my predictive model shows that they will be a more expensive person for the state in future, whereas this person's going to add to the economy? What kind of expectations does that set up for people? It's, it creates all sorts of value judgments we might want to avoid. So, and those things really aren't being examined in any great depth. And likewise with AI, it can be, as I said, some of these impenetrable forms of AI, even the people who've developed them don't really know how the outputs were computed, because they've gone on this great, enormous pinball machine of calculations to produce the output. So we have real problems there, and many people, I guess, like me, have argued that we need absolutely transparent AI that can be reverse engineered if we're going to use it in medicine. Otherwise, it's just experiment. It's just kind of research and blue skies. But really, if we want to use something reliable, we need to take it apart like a machine, and we need to be able to, work out where the glitches lie. I'm not sure if that answers your question.
No, that's very helpful. Terry, do you want to comment? We may have lost Terry.
Unfortunately, we have. He's trying to get back on, Brendan.
Oh, okay. Kang, are you there? We've lost Kang as well.
Lost Kang. Oh, well, that's okay. I mean, we can.
Oh, I'm here, so good. So I was muted. So anyway, are you asking me to answer the same question, or you want me
I wondered whether you had any comments, particularly in China, where I guess attitudes to privacy and data handling are probably different from in Europe, etc.
Well, I mean, I think it is different in terms of individualized countries and the regions, but there are also data sharing and the privacy laws that is sort of actually universally observed. And then I think the HTAi regulations, as well as the other privacy related issues, are actually gold standards across the globe. And certainly the way we conduct ourselves are actually in compliance with those actually rules. And obviously it is challenging to actually study some of the data where it cannot be sure you can completely strip off the personalized information. For example, even we are using EMR data, and then there will be preference. There will be sort of like trace of signatures that is actually potentially still being embedded into the system. So that's why there were ways we're thinking about to minimize that, for example, by only actually using secondary data and structured data that basically is being actually uniformly reduced to a pattern, pre-formed pattern, to actually minimize the differences in each individualized data set. In addition, so I think there were also different coding methods, and some which are, for example, federated learning and blockchain technology that will be able to hopefully actually, without getting data into a common shared database, still be able to learn from each other. And so those are some other approaches that potentially can be used to reduce or minimize the risk of privacy violations.
Thank you, Ken.
Thank you.
Lucy, do we have some questions? Do you want to run with them?
Sure. So we have a question coming in from Paul Finessi, who's based at the Department of Health in Melbourne, Australia. And Paul asks, while it's certainly clear that we're heading in the direction of implementing AI in clinical settings, as Terry spoke to, lots of clinicians are using pajama time just to keep up with the evidence as it is. So how do we expect the clinical community to be able to take on the new skills that they need to implement AI in the setting?
So, Claudia, you're online. Do you want to go first?
Well, it's easier said than done. And I think, I'm involved in a few initiatives around this, including some data science teaching and for doctors, but also the NHS Digital Academy, and which is again trying to sort of upskill medics mostly and clinical informatics officers on some of these issues. But there's only so far you can go unless people are willing to sort of engage in proper study. And what one thing we've been advocating is to try and bring it into the undergraduate curriculum, actually, before people are let loose, to make sure that most doctors have a familiarity with the principles, but also using clinical information systems that perhaps integrate AI and understand some of these core concepts around data science and AI. Because, I think just as public health has become a data science, I'm not saying it's all about AI, but public health is, always was driven by data back from the early days of epidemiology, but it's become very much a digital data science now. So there's been a kind of conversion that has been recognized to such an extent that public health and research are, academic research and policy research, they really are pretty similar. But in clinical practice, it's not been quite like that. So we haven't yet seen that flipping over from traditional medicine into digital medicine. And, we're fighting a tide because it's coming along not only in the, the need to use technologies while working, but also interacting with patients, but processing information, but also, in terms of clinicians being able to generate these new actionable insights themselves from being able to query data sets, for example. So I think it's a challenge. I don't think we're going to, unless we recruit more people with the right expertise into medicine, it's going to remain a challenge. But fortunately, things are becoming a lot easier at the front end. So we have things like increasingly we are looking at a potentially more realistic option for automating systematic reviews, particularly for areas where the research is fairly structured, medical, particular types of drug research, for example. You have certain expectations about the papers, not so easy in social research. And automated systematic reviews built with things like also maybe machine learning, natural language sort of technologies and perhaps some sort of kind of AI to bring you that information in a simplified, synthesized, up to the minute form on your phone or your laptop is a great way to overcome this problem of pajama time for people reading the literature sort of randomly, actually, and perhaps we'll have much more personalized methods of feeding relevant information to clinicians rather than expecting them to go out and search for it, for example. So there is potential for us to do that. And likewise, data visualization, which can be automated to some extent, is becoming much more sophisticated. So, you know, there's been a recognition that our brains are only so big and all the data is enormous and kind of exploding like a nuclear cloud. And actually, what we need is a rapid summary. I don't want to name particular politicians who are well known for asking for the sort of one-page summary rather than reading a whole policy report. But you know, if done correctly with the right data visualizations and with the right synthesis, you can, in fact, incorporate a huge amount of information very, very quickly. So I think we have some light at the end of the tunnel through these methods of automated synthesis and presentation, and things that are perhaps designed, possibly with psychologists as well, in ways that allow them to sink into your brain a lot more quickly, because you know, you get to the crux of it, and that's really the only way I think we're going to be able to cope with this.
Thank you. Terry, have you joined us? No. Kang, I noticed in your examples, they were mainly aimed at improving the efficiency of clinical practice. But do you want to comment?
Yeah, actually, I'm actually far more optimistic than Claudia, and as a practicing physician, and I actually personally experienced being actually taught as a medical student and working as a resident, and then actually get up 3, 4 in the morning, try to chart down actually the sodium, potassium, and the in and outs in the surgical wards. And then as a physician, a practicing physician, actually using paper charts as to the last few years and where the whole system in the United States were transitioning from essentially a paper-backed charting to Epic system, where I'm not going to say much about how terrible the system is. Actually needs so much improvement. Anyway, so in this process, I do think that you know, having been able to make a transformation and then to having AI to synthesize prior information and then actually find important drug-drug interactions, so we can only remember 1 or 2 degrees of connections. So there's no way for us to actually find or memorize you know, whatever, actually 1,000 or actually you know, drug-drug interactions. That's just humanly impossible, and then that basically means we're bound to make drug errors, and if we practicing enough actually you know, essentially events, and then that's one thing. And the second thing is actually, like you alluded earlier, there's no way for us to keep up with this avalanche of information, and we can even actually figure out which one's fake, which one's not fake, and then so using AI to mine underlying data, and then to actually synthesize and make the best recommendation for us, and make that actually at the fingertips, just like when you get up actually in the morning, the Apple News, you know, synthesize information from New York Times for you, is one of the examples of how you can actually hopefully get a balanced view of the world, and then that actually can be, I think, is actually dramatically actually reduce the so-called JAMA time actually reading by going through different journals and try to figure out yourself. And I think that's, you know, that's actually that was actually what actually IBM Watson was trying to do in the past, you know, 2 decades in oncology. Unfortunately, I think they choose the wrong field. I mean, in my personal opinion, to go into, and they could be actually probably having a much easier time in pediatrics or actually internal medicine, for example. But anyway, so what I'm trying to say is actually clearly actually from my standpoint as a practicing physician, which we are in the process of implementing in many places in China, including Macau University of Science and Technology. Right now, we're just actually switching our servers and the electron health records into a cloud-based system where it will interact with the in-hospital physician's phone and potentially patient actually smartphone. So they will be able to seamlessly connect it together and then be able to using AI to triage at first line and then and to actually essentially put them into different actually categories and not only for sufficient utilization of the healthcare resources, also being able to actually diagnose conditions far quicker and far cheaper than what we actually used to do. So I remember when we published our Nature Medicine paper for diagnosing pediatric diseases using AI, New York Times actually wrote an article commenting on our paper, saying that this fact, which actually gave me actually very deeper impression. It basically says that each year that you know there were 11 million basically people going to the ER and being misdiagnosed, and because essentially the physicians who are in different capacities and different specialties, and they can't just see everything, and they might be tired, and and then so they will make mistakes, and then average ER visit in the United States takes 7 hours and it costs at least $700, and for which actually some of the very small easy diagnostic can be easily done online. And I hope that this pandemic was able to push towards that direction. I see some of the effect at least in China side, and hope that will actually be spread out and in other parts of the world. So the bottom line is actually what I'm hoping for is actually in the next 5 to 10 years, a physician will come to a clinic or actually seeing a patient with a smartphone or iPad with all the patient's information preloaded, diagnostic sorted, recommendation made. All they need to do is actually look at the data and then agree or not agree, or add it to the data, what they think, or synthesize new information, and then bring that and then make actually a few conversations with the patient, make a diagnosis, and then make a recommendation for treatment, and then spend the rest of the time talking to patients. Really bring back the reports, the time that we actually greatly lost, that the physician patient interactions, and then to actually synthesize new knowledge. So that's what I'm actually hoping that AI will do for us. For example, when I was seeing retina patients, I have 30, 40 patients in half a day, and then on average I have to see a patient in 5 minutes. It will be enough for me to synthesize all the information, pull out all the prior history, and then put it into my brain, and I look at the scans, and then I will just have probably 1 minute left. I have to do a quick exam of patient's eye and talk to them within half a minute, and then make essentially that will be basically a conclusion of this 5-minute visit. And obviously, I didn't do much interactions with the patients. It's very hard for basically being actually a human or as a physician at this day and age. And I hope that AI will bring back a lot of actually that actually human spirit and connections.
Thank you, Kang. Lucy, another question?
Brendan, there are certainly some more questions. We've run over time, and it seems as if the technology is not with us, but we will be broadcasting the session online for those in North America, and there are lots of people trying to get on. So wondering if we could perhaps continue online. Does that work?
All right. Yeah,
Sure.
well, I think maybe are you suggesting we go for another 5 minutes or so?
Yes, if people are still happy to chat,
Yeah.
It's been absolutely fascinating.
Yeah. Okay. Next question, Lucy.
Sure. So the question to Claudia. So we've been seeing that AI and big data are really methods. However, perhaps AI, real-world evidence, and big data could be seen as technology imperatives. Do you agree? And if so, what are the main challenges, especially for countries with limited budgets? And that's coming in from Via Otwin, who's in the Netherlands and is Vice President of the Society.
Thank you. I hope I can stay online because my computer is not charging at the moment. So I've got 11% to speak to you on. I do my best. Yes, I think you've raised a good question about low-income countries. And just to go back to what Kang was saying, you know, these are just new tools, new innovations, new progressions of computing technologies that make our lives more efficient and save time and allow us to bring together information quickly. As you know, in the clinical context, you know, nothing wrong with that. You know, that these are just natural progressions. It's this sort of concept of this kind of weird new world of everything being completely different and clinicians being made redundant and you know, humanoid robots replacing a real doctor. That's what is upsetting to people, but also some of those perhaps you know, the different difficulties if there's a ghost in the machine, if there's a glitch in the machine that perhaps could lead to false or biased outputs. For example, clinical robots that are drawing on big data for you know, using existing evidence to create algorithmic advice on your symptoms. Now, there was one recently put in women and men put in symptoms. This was a Babylon chatbot. Put in symptoms of similar sort of heart palpitations and so on. Exactly the same ones, in fact, were put in as a man and as a woman. And the results that came back suggested that the woman had anxiety and the man should go and see his doctor because he had a heart problem. So that just shows you how value judgments can creep in. Now, clearly, it was probably working as it said it was working, but the evidence base is probably based more on research that had male subjects. So there were biases all the way through from the source information, through the algorithms, into the outputs. But the outcomes were wrong, and you could see that working on, you know, racial groups, for example, different social classes, and that's a challenge. So I've lost my train of thought there, so I'm looking at my clock there. But in terms of your, can you just repeat your question, Via?
I think it was about the impact in low-income countries, Claudia.
Oh yes, I mean, I would just say I've also been looking at the low-income countries. Obviously, I'm interested in Africa in particular, and the way in which some of these tools actually can be very helpful. Now, they don't necessarily require you to invest in giant supercomputers. A lot of it can be done via cloud-based computing. The processing happens, you know, perhaps in some server farm in the Arctic, for example, which is where a lot of them are because they put out so much heat. So, you know, it could be happening there and just being delivered to you via the internet. But there's also more edge computing, things that, you know, AI on your device. So you can load it up, basically, and it's doing the same kind of calculations on your device, in which case it is much more portable and you can use it when there's no Wi-Fi around. So those things are possible. And I think some of these have great potential to deal with some of the, you know, global inequalities that we have. For example, in parts of Africa, you know, you might have one doctor for 20,000 people. And that's just, so the types of problems we have is completely different than we have in a high income country. And a chatbot, flawed as it might be, may be the best thing you have. It might be really, really helpful. So I think we also need to have much more nuanced discussions about fitness for purpose, fitness for context.
Fantastic, thank you.
You know, benefit trade-offs that we have in different contexts is important. Sorry.
I think we're losing Claudia, are we?
You're losing me. My computer's running out.
Is going.
I'm sorry.
No,
That's all right. Terry, did you join us? No. Kang, I think probably we're at a stage, Lucy, where we should wind up. I think it's been a fantastic session. I think it has progressed our knowledge and understanding of the issues that we're going to be faced as health professionals in all walks of life. And I think we've just been very privileged to have three very fantastic speakers, Claudia, Kang, and Terry. So thank you all very much. And as you say, Lucy, this will be recorded and able to be on the HTAi website.
Yes, yes. Thank you so much. It's been very, very interesting.
Okay, thank you so much. That was brilliant. Thank you.
Thank you so much. Good to see you all.
Brendan.
Thank
Take
you.
care.
Bye-bye.
Bye-bye.
Bye.